and welcome to Global Academy of Medical Education GAME. This is Dr. Sunabha, your OBS-GYN faculty. I did my MS from JIPMER and subsequently I did my DNB as well. So today we will be discussing one of the most important, one of the most concept-based topics for your PG entrance exam, particularly INI-CET exams and NEET, that is CTG and NST. So first let us understand what is CTG and what is NST. So the full form of CTG is cardiotocograph. Now the graph that is generated, the result graph, the technique is known as graphy and the machine is known as gram, but CTG, the paper, the plot that has been shown to you is cardiotocograph. So it has two components. One is the cardio and another is the toco. So cardio means heart. So this is basically fetal heart rate tracing. And toco is related to pressure. Tocos is the word for pressure. So toco is pressure. Pressure is basically uterine contractions. Uterine contractions. So this is basically a time-based plotting of the fetal heart rate as well as maternal uterine contraction on the same graph paper and representing it graphically. So what is NST? So let us understand what is the full form of NST. NST is non-stress test. So what is stress? Stress in obstetrics is refers to the term as labor, like stress dose of steroid, like that. So stress basically refers to the labor when there is a lot of good contractions and action, descent of the head, everything happens. So there is a lot of stress to the mother as well as the fetus. So stress, you understand that stress refers to labor. So non-stress test is the same test when the mother is not in labor. And what is the definition of labor? Labor is basically uterine contraction producing cervical changes. So when she is not in labor, there is no uterine contraction. So there is no need to add the toco part. So basically, simple terms, if we do only the heart rate tracing of the fetus against time without uterine contraction, it is known as the non-stress test, right? So let us now see the equipment. Here, if you can see, this is the instrument, right? So there are 4 types of probes. This is the ultrasound transducer 1, ultrasound transducer 2. This is kept in all machines internationally are like that, where there are 2 US and there will be 2 US outputs as well, US 1 output and US 2 output on the screen, so that we can simultaneously see the heart rate of the twins. Now this is the toco probe, the pressure transducer, and this particular thing is particularly important while we are doing non-stress test, not very important when we are doing a CTG. So when we are doing non-stress test, we can give this thing to the mother, and this is kind of a marker, so the mother can push the button whenever she feels there is a baby movement. So we can, and that puts an arrow mark on the graph paper as well. So we know that okay, baby has moved this many times during the test, and since during labor the baby doesn't move so much, so during labor or during CTG this has not much importance. So you can remember like this. Suppose it's not a twin, singleton. So we have 3 probes at hand, right? So we have the pressure transducer, we have the fetal ultrasound, ultrasound probe, which is a piezoelectric probe, which picks up the fetal heart rate. And since it is a piezoelectric probe, this needs a gel interface. We'll discuss this later. So for CTG, we need to put these 2, the toco and the fetal heart. Whereas when it comes to doing an NST, we will give, we need to put these 2, the cardiac probe and the maternal movement sensor. So these two for NST, these 2 for CTG. Like that you can remember. So let us see the probes now. So this is the US probe. This is a piezoelectric probe, as I have already discussed. So this has piezoelectric crystals, and that's why you should handle this very carefully and should not drop, because if you drop, the orientation of the crystals change and the interpretation of the movements picked up also change. So since this is a sound transducing element, this surface needs to be covered with a gel interface, right? On the other hand, this is the pressure transducer. Can you see there is a concentric ring inside? Here also the same thing. Can look different, but it's basically the same thing. If you see, there is a pressure sensing button in between the probe. Whichever way it looks, these are the pressure probes. So this is the sound probe and this is the toco probe, right? So let us now directly go to a NST. Sorry, this is CTG because you can see the contractions, right? So what are the normal characteristics of the CTG? So what are the things that we look for? First of all, we look for the baseline heart rate. So baseline heart rate is basically somewhere around here, where most of the, if you find a quiet zone, the zone around which the cells are, the lines are oscillating, that is the baseline. So in this case, we can see the baseline is around 120 bits per minute. So these small variations, which is less than 25, less than 10 to 15 bits per minute, these are known as the bit to bit variation. And for a longest curve, the highest point in a, if you take this area, the highest point, highest positive reflection, highest upwards reflection and the highest lowest downward deflection, this is considered as the variability, right? If there is a peak, which is more than 10 to 15 bits and which is persistent for 10 to 15 seconds, that is known as an acceleration. Which is basically, see, if we exercise, we will get tachycardia. So if the fetus moves, the fetal heart picks up the beat and it is shown as acceleration in the beat. So in case of NST, the baby movement should actually correspond to the accelerations, right? If there is a drop, like this, heart rate suddenly drops to a very low level, like at least 10 to 15 bits per minute from the baseline for a good duration of 20-30 seconds, that is known as a deceleration, which is actually not a good thing. Acceleration, if it is a CTG, if she is in labor, the baby is not moving much, so acceleration may not be there. But if it is an NST, there should be 2 acceleration in 20 minutes. There should be at least 2 acceleration in 20 minutes. And there should be no deceleration. What should be the normal baseline? The normal baseline is 110 to 160. Above 160, it is known as tachycardia. It is known as fetal tachycardia, whereas less than 110 is known as fetal bradycardia. Variability, let us discuss variability in the next slide. So now if you see this one, this is a clear-cut baseline of 150. There is a clear-cut baseline of 150, right? So the variation you can see is very less, right? So this is a CTG of reduced variability. So we call normal variability is 10 to 25 bits per minute. If it is more than 25 bits per minute, that is a sign of fetal irritability, and this is known as a hypervariable trace. It's not normal, right? If it is less than 10, it is known as reduced variability. Whereas if it is 2 or less, it is known as nil variability. 5 to 25 is the normal range. So if it is less than 5, like 3 to less than 5, it is known as reduced variability. Whereas if it is less than 2 or 2, it is known as nil variability. So 5 to 25 is the normal range of variability. So in this case, we can see like variability is definitely less than 5. So it is a case of reduced variability. Now the decelerations, now here you can see the decelerations, right? The fall from baseline, sharp fall from baseline and then recovery. So these are decelerations and these are generally not normal. Now decelerations are to be always interpreted in relation to the contraction. So there are 5 types of deceleration. One which comes with the contraction, which we call as the early deceleration. See, if you see the peak of this acceleration, and the trough of this deceleration, here also the peak of the deceleration, sorry, the nadir of the deceleration and the peak of the contraction is corresponding. So basically they are mirror images of each other. So that is what is early deceleration. If the deceleration comes after contraction, like if this is the contraction and this is the deceleration, that thing we will call late deceleration. We will see the causes of it. Remember, late deceleration is the worst among the commonly encountered decelerations, and that's why probably your seniors in labor room also asked you, or in your exam also your teachers have told that to check ausculted fetal heart after a contraction. In labor room, always fetal heart monitoring when you are doing by intermittent auscultation, it is always suggested that you do it after the contraction passes off, because your idea is to pick up the late decelerations. Late deceleration should not be missed, the others can be missed, right? And if it is not corresponding in any way, that is known as variable deceleration. Now there are 2 more types of deceleration that you will not see every day. One is spontaneous deceleration, that is there is a deceleration without any contraction. So there is no stressor on the baby and the baby is still decelerating, which is actually pretty bad. And the worst is actually prolonged deceleration, when the fetal heart rate suddenly falls and never picks up. So this needs urgent cesarean. It goes below 60 and stays there for roughly more than 2-3 minutes, right? So that is prolonged deceleration. So these are the 5 types of deceleration. So here you can see an early deceleration, which is the least pathological. So this is a variable deceleration. You can see there is contraction has long gone, and then one deceleration has come. Here between 2 contractions, one deceleration. So decelerations have no particular order. So this is variable deceleration. Now I'll tell you one thing, how to identify these things. So it's actually very simple. See, in labor, so silly mnemonic actually, in labor what comes first? What comes early? It's cephalic presentation, the head, right? So early deceleration, head is early. So early deceleration is basically due to head compression. So when the head is trying to negotiate through the pelvic planes, the head is getting compressed, and because of that there is deceleration. Now once the head is coming and trying to pass off, so it tries to pass off, one contraction and simultaneously one deceleration, again head tries to pass off, again one deceleration, and after a few, actually the head will negotiate through that plane and then there will not be a deceleration. So early deceleration can be physiological as well, unless the heart rate is falling very low, like till 60, it's coming 760 or below, or there is fetal tachycardia, or there is less variability, or there is repeated early decelerations for a prolonged time, which means the fetal head is trying to negotiate but it cannot. So there is cephalopelvic disproportion underlying, but otherwise simple 1 or 2 or a few non-repeated means in less than 50% of the contractions, the presence of early deceleration is not actually pathological. So head compression, early deceleration, and what comes late in the delivery is the placenta. So late deceleration is due to placental cause, right? Uteroplacental insufficiency. And what is of variable length is the cord. So variable deceleration is associated with the cord. So this is a silly mnemonic. Head compression, early deceleration, because head comes early, late comes the placenta, so late deceleration is associated with the placental causes, and cord is the variable length structure, so cord compression is associated with variable deceleration. So that is why for variable deceleration, the treatment of choice is position change. Position change, putting the mother in left lateral position or on all fours like Gaskin maneuver, right? Number 2 is hydrating the mother so that the cord pressure increases. We stop oxytocin, or any other augmentation that is going on, because the cord is getting compressed between the uterine wall and the fetus, so we reduce the contractions, so we stop oxytocin and give high flow oxygen, at least more than 10 liter per minute, high flow moist oxygen to the mother to improve the oxygenation level to the baby for preventing hypoxia. So here is the worst form of deceleration among the commonly encountered one. You can see it's not like variable deceleration. See, this contraction has passed away, passed off, and there is a deceleration. Here also same thing, contraction, just after that there is a deceleration. So this is late deceleration, and this is seen in uteroplacental insufficiency. The same necessitative measures that we discussed for our variable deceleration can be used for it, but again situation to be assessed, and cesarean arrangement has to be done even if we don't take an immediate call, because this kind of picture is seen in actually the AEDFs, REDFs, the compromised Doppler, or fetal growth restricted babies. So this is our prolonged deceleration, so it has to be down for like more than 2 minutes, and then it goes up. So this is a case of prolonged deceleration, and this usually needs an urgent cesarean, or if there is a emergent cause, the cause reversal, right? And this is most talked about, but nobody has actually, I don't know anybody who has seen it. Like, I was in Jipmer for 3 years. We had a CTG machine for every laboring cot, and 24 hours every patient CTG continues to run, and I have still not seen a sinusoidal pattern yet. But this is the sinusoidal pattern. Remember, there is no variability, no baseline. See, there is no baseline and no variability. There is no bit to bit variability. There is no like this. It is not like this smooth curve, right? So no baseline, no variability. So this pattern is sinusoidal, and this is one of the worst prognosis among the CTGs. And remember the causes. This is a thing when there is bleeding from the fetus itself, like vasa previa, or severe anemia of the fetus because of hemolytic reasons, because of hemolytic disease, or any other cause. So this kind of picture is theoretically seen in patients who have severe fetal anemia. There is a fetal blood loss either in form of hemolysis or direct bleeding from the fetus, like in case of a vasa previa. I think that summarizes all the possible graphs and image based question that can come in your INI-CET exams. So I wish you, all of you, all the best for upcoming INI-CET exam and all the upcoming exams, and in general for your life. Do well in exams, and I hope you will be able to solve 100% of the CTG or NST based image based question. Best wishes from GAME. Let's play it.